Local people, important issues. CBS 10 WILM's weekly focus on the Lower Cape Fear region. This is Byline Wilmington with your host, Don Ansell.
Welcome. A very good Sunday morning to you. Well, on the heels of some big news this week about a breakthrough vaccine for prostate cancer treatment, today we're talking to one of the leading specialists in our area about the #2 killer of men, that's prostate cancer, and about the controversies surrounding testing and treatments and prevention, and this new vaccine that some say could change the way we treat other types of cancers. So a buddy of mine, my doctor, and a well-known specialist in the area, Dr. Will Russell, who is a urologist, is joining us. Will, thanks for being here.
Thanks for having me.
Yeah, great to see you. And in the interest of full disclosure, let me say that I was diagnosed in 2007 with prostate cancer. Dr. Russell was and is my urologist. It was treated successfully, and I'm disease-free today, I think, as far as my last test was,
Sure.
right?
Yeah.
Which has been since 2007. So I have a background sort of for the questions we're going to ask. But you told me, and I think everybody kind of knows that if the word is if you're a man, you live long enough, you'll get prostate cancer.
Sure. So I've read something yesterday that the way to roughly estimate what percentage of people have prostate cancer on autopsies, people who have their entire prostate removed, you take your age, and it's that. So if you're 50 years old, you have 50% of men will have some microscopic area of prostate cancer on up into your 80s and 90s. But yet it's not, you know, even men who are 50 years old, there's not a 50% chance that they'll die of cancer in the rest of their lifetime. So.
And you have a large practice. What percentage of your male patients are diagnosed? Do you have that with prostate cancer
Sure.
every year?
Well, you know, of course, I'm seeing people for prostate cancer. The overall likelihood in a lifetime of getting prostate cancer is about 10%.
Really?
And that's clinically
That's
diagnosed
low.
prostate cancer.
That I would have suspected.
Sure. And you know, it's interesting because it's not much different than breast cancer. And breast cancer happens to occur in women at a slightly younger age. But
Right.
So whenever you have discussions about screening, treatment, and everything, it's interesting to look at the difference between breast and prostate.
How long have you been practicing?
18 years.
18 years. And has the percent of cases of prostate cancer grown?
Oh yeah, I think so.
Over that
Because
time?
of screening.
Because of screening. So it might not have grown in incidence, but in detection.
We see a lot more prostate cancers, but now it is extremely rare to see that person with a prostate cancer that's kind of out of the barn, that's not treatable, or that's metastatic.
And yet it's the #2 killer of men.
True.
So,
True.
It's getting out of the barn for a lot
Sure.
of men. Is that because people aren't going for
Yeah,
diagnosis?
well, I was reading, they said that somewhere around 60% of men by the age of 57, that's an arbitrary number, will have been screened for prostate cancer. So the other side of that is a lot of men are not getting screened for prostate cancer. And it tends to go with your economics, your insurance status, and men are not the consumers of health care, the women are. Women are accustomed to annual visits for pelvic pap smears and screening. I mean, I'm a man who goes to see a doctor when I've got something wrong with me. I'm not the kind of person who religiously goes to the doctor every year. And I think most men are, that's typical of most men.
I was surprised when a few years ago, Merv Griffin, one of the wealthiest people in America in entertainment, died of prostate cancer. Now, does that indicate to you he didn't go to the doctor? Or he went too late to...
Right. There will always be a subset of prostate cancers that everything that you do will still not be enough to catch them because they're these poorly differentiated, fast-growing, man-eating prostate cancers. That's a very small minority. That's probably 5%. You know, you have three real groups of cancers, and this is not true of prostate or anything else. You have the subset where it's not going to kill you no matter what, but you can find it if you want to. There's the middle group where if you let it go far enough, long enough, it will kill you, but you certainly have a large window of opportunity to get it. And then there's the other where it's kind of like being struck by lightning.
And is this true for all cancers? or
Well,
prostate?
I think it's true of all it's probably true of all prostate cancers to some degree, but obviously things like lung and pancreatic cancer,
You don't want
the
to find out
survival
which
of
one.
esophageal cancer, 5% of people can be cured, and nobody recommends non-treatment.
So there's three subsets of how it can progress, and is it up to you to decide which one it is, or to advise?
Right, and that's the challenge.
That's
I
the
think
challenge.
that's what, when they talk about prostate cancers, you don't, if you think that, for example, that 70% of the prostate cancers out there are these, what they call autopsy cancers, cancers you would find if you autopsied men, and that's probably a reasonable estimate. You don't want a test that finds those.
And they don't need to be treated.
And they would not need to be treated, sure. Then what we do is generally we do it by age, other health conditions, and things like that. The current recommendation, and this recommendation really hasn't changed, is if you aren't going to live for 10 years due to other health conditions, you probably shouldn't be looking for prostate cancer. And
You probably, say that again, you probably
should not be screening for
should
prostate
not
cancer.
be screening.
Because prostate cancer is not your greatest risk.
Gotcha.
And so it's always a challenge to
Well, how do you
stop
decide that this is a slow-growing cancer, it's not going to inhibit, it's not going to kill you? Are there signs?
Sure. And I guess let's get the general screening method is a prostate exam, feeling for any lumps or nodules in the prostate.
And that's the one that men really
that's
resist.
That's probably what keeps them out of the office. And then the other one is the PSA test, prostate-specific antigen.
And that's a blood test.
It's a blood test, and so that's generally not a problem for folks. But you're not going to be able to tell from a PSA test or an exam whether this is we call it a low, medium, or high-grade prostate cancer. So you end up getting a biopsy, and then the biopsy can tell you, is this an aggressive cancer or is it not? And they're pretty good at calling the grade of the cancer, high grade being fast-moving, low grade being slow-moving. Also on a biopsy, you find out, well, how much of the prostate has cancer in it. If you biopsy the prostate, say, with 12 biopsies.
12 little snips of your prostate from different
Sure.
angles. I've had it twice.
Oh, yeah.
It's not terribly comfortable. It's not awful. But
Yeah, but it's not much fun.
we're going to take a break, and we're going to come back.
Okay.
There are controversies about the PSA test. We're going to talk about those when we come back with Dr. Will Russell. Stay with us.